the cloud. All right, for everyone joining us, welcome, welcome. We're going to get started in just a couple of minutes. We want to give everyone some time to get situated in the Zoom. In the meantime, let me give you host privileges. Wonderful. All right. One more minute.
Okay.
All right, everyone. Thanks for joining. My name is Samira. I am an NMO patient. I'm also the founder and executive director of the Samira Foundation. And today I am excited to introduce all of you to Dr. Benjamin Osborne. He is a neuro-ophthalmologist at Georgetown University. And today he is joining us to discuss COVID updates as they relate to NMO and MOG patients. So without further ado, I will pass it off to Dr. Osborne. And just before I go, I wanted to let you all know that this session is being recorded and it will be available for replay on TSF's YouTube and Facebook pages. And we will have ample time towards the end of the webinar to answer any questions that you may have for Dr. Osborne. So Dr. Osborne, the floor is yours.
Thank you, Samira, and thank you for allowing me to give this update on COVID and NMO and MOG disease. On behalf of the Samira Foundation for NMOs from the Expert Series. I also like to thank Horizon Therapeutics for making this program possible through a patient education grant. A little bit about myself. So as Samira said, I'm a neuro-ophthalmologist and neuroimmunologist here at Georgetown Hospital in Washington, DC. I got involved in treating NMO patients when I did my fellowship in neuro-ophthalmology at the University of Pennsylvania. Way back in 2005. And I ended up seeing a lot of patients with optic neuritis. And as you can imagine, not only did I see patients with multiple sclerosis, but I saw patients with NMO. And then later, now more recently, it's been described seeing patients with MOG optic neuritis. And so when we're talking about what I could give an update on, initially I was thinking, oh, well, maybe I'll give an update on neuro-ophthalmology and vision problems related to NMO and MOG. But then we were discussing this and it seemed like it was a good time to do a COVID update. And wow, what timing. I mean, just yesterday and today, as I was revising my talk notes, I kept having to make changes because new updates were coming from the CDC and the FDA. I'm sure you're aware the FDA updated the emergency use authorization for the Pfizer vaccine for children now, which is super exciting news. And we'll talk a little bit more about that. But I thought we would just go back and revisit, I think the last major update on COVID was actually by Dr. Michael Levy about a year ago or so. Maybe I might not have the exact date correct. So before we talk about what's new, maybe just think about where we were a year ago with COVID. So we had no vaccines available to treat this disease. The vaccines were still in the clinical trials. And so the only people who had access to those were those brave participants who were in the trials. And we're very grateful for those people who went into the trials. We had no treatments available. We actually don't talk about as much as the vaccines, but there are now a lot of treatments available. Remdesivir you might have heard of, which is a treatment for people who are hospitalized with COVID. And then there are the monoclonal antibody infusions. There's 3 FDA approved monoclonal antibodies that can be used to treat patients who have milder forms of the disease before they are hospitalized. And I think the other things that are new, we have a new president. That's not really directly related to COVID or NMO, but I'm just thinking about what's new over the past year. And then we've had this whole change in the evolution of the vaccines. You know, initially we had one vaccine approved, and then two, and then three. And then after the vaccines were approved, there were questions about, you know, we didn't know how effective they would be. And it turns out they're super effective, some of the most effective vaccines ever made in the history of vaccines. Concerns came up about their safety, and fortunately, they're very safe vaccines. All three of the ones that are available in the United States. And in addition, then the whole issue of boosters came up. And so we can talk about that. I was going to address some of the issues that arose with the booster vaccine doses. And also now the pediatric vaccine is available. Should people with NMO, if they have kids, should their children get vaccinated? Or if there's pediatric patients with NMO, should they be vaccinated? Is it safe? So just to revisit broadly, I guess, in general, when we think about NMO and COVID and MOG, we don't see any signal that the disease is worse in COVID patients or NMO patients who get COVID infections. I think that's been dealt with previously, but we do have more data now. There's a database called COVIMS, which is a North American database. It is predominantly multiple sclerosis patients. So I believe about 80% or so of the patients in the registry are patients with multiple sclerosis, but they do have a small percentage of patients who have NMO and MOG disease there. And doctors can go and actually register data. It's de-identified, so it's anonymous. There's nobody's name is identified, but it basically collects data on how old's the patient, gender, what disease do they have, how long have they had the disease, what were the initial symptoms of the COVID infection, and then what was the course of the COVID infection if it's known. Did the patient get hospitalized or not? Did they have mild, moderate, or severe disease course, and how much of a recovery was found? And then I think what's real interest to all neurologists and patients is, what treatments were patients on? So while there's not enough data on the NMO patients alone in this database, we have learned a lot, I think, between this database and some other databases in Italy and France and Europe, that in general, the patients who have MS, who are on therapies that affect the immune system, in particular, I think what's relevant to NMO patients are B-cell depleting therapies, which include rituximab. Many patients are on that for NMO or MOG disease. There's an MS drug called Ocrevus, which is very similar to rituximab. There's another drug that's approved by the FDA for NMO called Uplinza, which is inebilizumab. This is another B-cell depleting therapy. There's been a lot of evidence, looking at patients who had COVID or on these therapies. There might be an increased risk of patients on these therapies having a more severe course. There's kind of mixed data on this. So we don't know exactly for sure that having any particular disease modifying therapy increases the risk. What we do know is that the patients who tend to get the sickest with COVID are the patients who have the other risk factors that we associate with more severe COVID disease. So that means being over the age of 65, being unvaccinated. So vaccination actually reduces your risk of getting severely sick from COVID. Having other comorbidities such as high blood pressure, diabetes, chronic heart disease, chronic lung disease, having cancer. So these are things that we know increase your risk of already having a worse COVID outcome. So we think that those are the same risk factors in patients with either MS or NMO or MOG disease that would lead to a more severe disease course. And I think with NMO in particular, if you're unfortunately more debilitated from a prior relapse, so if you have more pre-existing disability, maybe you're wheelchair bound, that might put you at higher risk because you already have some pre-existing comorbidity from being wheelchair bound that could put you at higher risk for having a more severe disease course if you caught COVID. But the one thing that's quite clear is that vaccination reduces the risk of dying from COVID or having a severe disease course. One of the frequent questions is, does it completely prevent, catching COVID? No, it doesn't. We know that it doesn't, but that's not really the expectation from a vaccine. Really, our expectation from a vaccine is to prevent people from getting severely ill or dying from a severe illness like COVID. One of the issues that can come up if you do, unfortunately, despite getting vaccinated, catch COVID is, one of the questions that might come is, can you get treated? So there are treatments now for COVID. If you have mild disease, you can actually get the monoclonal antibody infusions. There are now 3 of them approved by the FDA. So you have to be above the age of 12. And they work best if it's been less than 10 days since the onset of your symptoms. You can get them, specifically the people who benefit the most from the monoclonal antibodies are those above the age of 65. But again, as long as you're above the age of 12, you're eligible. Pregnant patients, so if you're pregnant and get COVID, there's a higher risk you're going to get sick from COVID. So the monoclonal antibodies are also beneficial in those patients. Obesity is a risk factor for more severe disease. So if your body mass index is above 25, and then if you're on immunosuppressive disease, if you have immunosuppressive disease or on immunosuppressive treatment, which I think is highly relevant to this audience, then the monoclonal antibodies would be something to consider doing. So these are done in an outpatient setting typically. And I think a lot of doctors might not be aware of this. So if you think you have COVID symptoms, even if you're vaccinated, unfortunately, you could still catch COVID. You might be eligible for getting the monoclonal antibodies, even if you've been previously vaccinated. So you could always contact your doctor to find out whether it's appropriate for you to get these. Again, they work best within 10 days of the onset of your symptoms. So it's important to get this earlier. It works better the sooner you start the therapy. It's not authorized once you're in the hospital. So once you're in the hospital and you need oxygen, you're more sick, then you might be eligible for one of the other treatments like remdesivir. There is an investigation to an oral therapy. It is not approved yet. They haven't even published the studies for it. But I think Merck is working on a pill, which would kind of be like remdesivir, but it's a pill form of it. And basically, they're presenting the data, I believe, to the FDA currently. And the FDA has to analyze it. It's called molnupiravir. I might have botched the pronunciation of that. But basically, this would be, I believe, a twice-a-day pill that you take for about a week or so, maybe a little bit longer. Merck is claiming, and again, I haven't seen the data, that it cuts the risk of hospitalization or death in COVID patients by 50% or so. But that's just based on their press release. I don't have, I've not been able to review the data on that. So those are major advances in the past year. We have antibodies available. We have antiviral treatments, currently IV, but potentially pills coming in the future. We have monoclonal antibodies. We have this COVIMS database. I mentioned that database earlier. I should stress again, there's not enough NMO and MOG patients in that database. So if anybody in the audience has had COVID and you're not sure if you've been reported in the database, you could talk to your neurologist and ask them to report you to the database. I don't think patients can do that. It does have to be a physician that can upload the information, but you can talk to your neurologist and they can update your information. Again, you wouldn't be identified, so it's completely anonymous, but this will actually increase our understanding of how COVID does affect NMO patients. So I think there's only about 2% and about the patients in that registry are NMO patients, and less than 1% are MOG, which is truly an underrepresentation. We know MOG disease is much more common, but the vast majority of the patient, they have about 3,300 MS patients in the registry. What I'd like to do now is there's been a lot of updates about the vaccines, and I know I was asked not to show slides, but I think just because this is so complicated, I do want to show a couple slides about this. So let me just pull this up. Let me just make sure you can see this slide. So this is the slide I wanted to show because the vaccines have gotten really complicated. Even this morning, I saw updates that I had to make to this table. And what it is, if you look there, the 3 major vaccines are listed here. So the top one's the Pfizer vaccine. That's already fully approved by the FDA. That's not even under the EUA anymore, the emergency use. That was fully approved by the FDA over a month ago. It actually has a fancy name now because once a drug gets approved by the FDA, they can give it a fancy name. So it's called Comirnaty. I'm not sure, I might be mispronouncing it. None of the other vaccines have a name yet because they're not fully approved by, they have the just EUA authorization, so they can't get the cool, sexy name yet. Moderna is there, and then the bottom one is the J&J or Janssen vaccine. The 2 top ones are the mRNA vaccines. You might be familiar with that terminology. That's messenger RNA vaccines. These are a relatively new technology for making vaccines that are highly effective. The J&J vaccine uses another effective but a little bit older technology called a recombinant adenovirus. None of these are live vaccines, so they're all safe if you're immunocompromised. So all patients who have NMO and MOG can get these vaccines. If you have generalized questions, whether you as an individual should get it, you should definitely discuss that with your own doctor. I'm not here to give individual medical advice, but I would say as a general broad recommendation, most MS specialists and NMO specialists are recommending their patients get vaccinated with any one of these 3 vaccines. One issue that might come up is timing of when to get the vaccine. If you're already on a therapy that weakens your immune system, there are some questions about that. Some of it might be if you're on a B-cell depleting therapy, you might want to get it like about a few weeks before your next infusion, or about 2 to 4 weeks before your next infusion, to allow the last dose of that vaccine series. A couple of these vaccine series require 2 doses. And actually, according to the CDC now, if you're immunocompromised, some of these are actually recommending 3 doses. So you can get, for example, let's just talk about the Pfizer vaccine. So it's approved if you're above the age of 12 now. I have to correct that, it says 16 there, but it's actually above the age of 12. And now, technically, with the EUA, I think now 5 to 11 has been approved as of yesterday, so it's a little bit more expanded. But if you're immunocompromised, so the standard dosing, if you're not immunocompromised, is 2 doses about 3 weeks apart. But if you're immunocompromised, you can get a 3rd dose. That should be about 28 days after the 2nd dose. That'd actually be 3 shots just to get the approved dose. And then after that, 6 months later, you could get a 4th shot, theoretically. That would be the booster if you're immunocompromised. That might sound confusing because we really haven't heard about 4th doses yet. But there are these differences between doses and boosters, and it gets confusing. But basically, the dose is the standard dose that anybody should get of the vaccine. And again, if you're not immunocompromised, the standard dose is for the mRNA vaccines, 2 doses. So that would be dose 1. And then for the Pfizer one, it's 3 weeks later. For the Moderna, it's 4 weeks later. But in patients who have weakened immune systems, who are on immunosuppressive therapies, they do recommend a 3rd dose, which can actually be given another month after that last or 2nd dose. So that'd be 3 shots. And then 6 months later, the booster is the idea, regardless of whether you're immunocompromised. The booster is that can be a tapering of the antibody response in everybody, whether you're immunocompromised or not. And so after 6 months, just to give a boost to the first set of dosing that you got, you can get that additional shot. So if you're not immunocompromised, that would mean you would get a total of 3 shots with the Pfizer vaccine. With the Moderna, also 3. But if you're immunocompromised, you theoretically could get a 4th dose if you're getting the booster. I know that's going to raise a lot of questions. That's why I put this slide up here. It's very confusing, and I apologize. Some of this might be an error because it's hard to keep track of all the CDC updates. They change frequently. Another thing is a little different between a booster and the regular dosing. In the Moderna vaccine, they cut the booster dose in half. So the regular dose, if you're getting the 1st and 2nd shots, is 100 micrograms. And if you're immunocompromised, you get the 3rd dose, that's also 100 micrograms. But then 6 months later, if you're getting a booster dose, that would be down to 50 micrograms. And that's unique to the Moderna vaccine. The J&J vaccine is a little different. So that one, it's an adenovirus vaccine. They don't have as much, I guess, data yet to make the recommendation to do the 3rd or even a 2nd dose. So that's a 1-dose vaccine. They are recommending patients can get a booster dose 2 months after the 1st dose, but that would just be it. They don't have recommendations for immunocompromised patients to get an additional, say, 3rd dose after that. So I'd say if you got the J&J, you can get a 2nd one 2 months after that. Now that I've utterly confused everybody, I'm going to move on to the pediatric information because that just came out yesterday. So this was big news yesterday. I'm sure a lot of you heard about this. This is on the bottom of the slide. I think this is the last slide I'm going to share. But the Pfizer BioNTech got the EUA approval for 5 to 11-year-olds by the advisory committee by the FDA. The FDA full committee has to go and approve this. And then next week, the CDC advisory committee is going to also review this. everyone is pretty much anticipating that the CDC is going to approve this also. And so probably what's going to happen is starting in November, kids from the ages of 5 to 11 can start getting the Pfizer vaccine. Currently, only children from ages 12 and up can get the Pfizer vaccine. That's the 12 to 18 range. Excuse me, if I go back to this slide, Moderna is only for 18 years and older, same with J&J. So once you're below the age of 18, you're in the world of the Pfizer vaccine, and had been up until yesterday from 12 and up. And and now, as of yesterday, we're looking forward to 5 to 11-year-olds being dosed. This is a much lower dose, so it's 1/10 the dose of the adult vaccine. And they studied this on a large number of patients. So these vaccine trials are very large. So you can see here, in just this particular age range of 5 to 11-year-olds, there was about 3,100 participants who got the vaccine and about 1,500 who got the placebo. And basically they found, like in adults, 90% effective in preventing COVID infections, highly efficacious. Just by way of comparison, the flu vaccine is usually about 50% effective on a good year. On a bad year, the flu vaccine might be about 30% effective. That's been the standard of flu vaccines for decades. I do recommend also, since I mentioned it, you get the flu vaccine, unless there's a particular reason you can't get it because you're allergic to one of the ingredients or your doctor has mentioned in the past you shouldn't get it. But in general, most neurologists who treat MS patients, NMO patients, MOG patients are recommending the flu vaccine also. So there's a lot of vaccines. Now's the flu season's coming up now, so now's the time to get the flu vaccine if you haven't gotten it. So let me stop sharing my screen. And I think those are the major updates I wanted to focus on, that we now have therapies that have been approved by the FDA to treat mild and severe disease courses. And patients with NMO and MOG are eligible to get those treatments if you do, unfortunately, get COVID. We have registries, so if you unfortunately do catch COVID, your doctors can put the information into the registry. That will allow us to learn more about how NMO patients do when, coping with getting COVID, and, how do the disease modifying therapies that you take affect your ability to recover from the disease. Oh, and that's one other thing I did want to mention. Just recently, in the past month, we've gotten a lot of information. Again, we're extrapolating from the world of MS about how well do people mount a response to the vaccines if they're on therapies for treating their MS. So there was a large study that was done by the group at the University of Pennsylvania, headed by a doctor named Amit Bar-Or. There was a large group, a lot of other researchers involved, and they published this recently, and they looked at patients before they got their vaccine, what their antibody levels were towards the COVID virus, SARS-2 COVID virus. Then they looked after the first jab, and then after the second jab at several different time points to see not just what their antibody responses were, but they also looked at their memory B cells and memory T cells. So a lot of hype gets raised about antibody responses to vaccines. But one thing to keep in mind is that antibodies are only a small part of your immune response to a vaccine. Your immune system is very complex, and you have memory B cells, and you have different types of memory T cells, including CD4 cells and CD8 cells. Don't worry, you don't have to remember all this, but it's important to measure the response and understand the response of people to these vaccines. So they looked at healthy controls who got the first and second doses of the mRNA vaccines. And then they looked at MS patients who are on a drug called Ocrevus. And Ocrevus, again, is very similar to rituximab. Many of you might be on rituximab or a similar drug for treating your NMO or MOG. And I'm thinking we can probably extrapolate this data, and that they did see a diminished response to the vaccine if you look at the antibody response. Some patients had almost no response. Some people had a mild response or a modest response, but it was diminished compared to the healthy controls. What was interesting, though, is that the memory B cell and T cell responses, while blunted, were not completely blunted. And if you really dug down into the nitty-gritty details, the CD4 responses were also slightly diminished, but really not as much as you'd expect if you were thinking about antibody responses. It was only mild. And this is where it gets really interesting. The CD8 cells responses actually outperformed the healthy controls. It actually had a heightened response. I don't know what that means. Does this correlate with a good response of immunity and that if you get infected, you'll be able to fight it off? We don't know that yet. But I think this is very intriguing data that says that not just your antibody response itself reflects how your body's immune system is reacting to a vaccine or a viral infection. There's actually other parts of the immune system involved in a vaccine response or to a viral infection, including, again, memory B cells and different types of memory T cells. And so I think everyone's very excited to see this data because it does help us, reassure, I think me and hopefully you, that there is a vaccine response that's helping, that is happening. It's just different. It's not that you're not having a response. It's just different than people who are not on medications that affect your immune system. So with that, maybe we can start addressing the questions. I think I discussed everything I wanted to highlight with my talk. So let me look here in the question box. I see my treatment is Plex every 5 weeks, and you had Rituxan in March and September. And I'm curious if it's beneficial for me to get the vaccine. I'm type 1 diabetic and I've had relapses easily when sick. So that's a great question. So when you get rituximab, that can blunt your response. I just told you we have that study, but we also have the data that you can still mount a vaccine response. And we know for NMO patients, who are getting rituximab and plasmapheresis, that we think it's generally safe to get vaccines. One of the worries we had previously was that if you had a vaccine or any infection that could activate your immune system and maybe trigger a relapse. But there's some data that suggests, it's retrospective, but it's the best data we have, that if you're on active treatment for your NMO, it should be safe to get the vaccine. So I generally do recommend getting the vaccine. Again, you should probably discuss this in more detail with your neurologist about the timing of that. If you just got rituximab infused in September, you might want to wait a little bit to get the vaccine, maybe about 4 months after the last dose of rituximab, to give your body's immune system the best chance. There's some data suggesting that if you delay the vaccine a little bit, you'll mount a better response with the antibodies. But again, we also have this data showing that even if you don't mount an antibody response, your T cells are going to respond. You could theoretically get the vaccine now and not wait 4 months afterwards. I think it also depends on how the COVID levels are doing where you live, what kind of work you do. If you work in an area like I do, I'm a doctor, I'm immunocompromised, so I definitely got vaccinated. I felt that I didn't want to catch COVID from a patient. I didn't want to spread COVID to my family or my patients. And because I have Crohn's disease, so I'm taking medications that weaken my immune system. I got the COVID vaccines myself. I got the first and second dose, and then I got a third dose. I haven't gotten a booster yet. I guess I'm eligible, I think, now for a booster, technically based on what the CDC says. Next question. If rituximab cannot be postponed, what should I be aware of since I'm not vaccinated? So typically, rituximab is dosed every 6 months. We generally do not recommend postponing the treatments for NMO at all for the vaccinations, because that's just generally too dangerous for your NMO to have breakthrough disease. Generally, my recommendation for my patients with NMO or MOG disease who are on rituximab is just to get the vaccine whenever you can. Sometimes we like to adjust the timing of the vaccine around the timing of the infusions of the rituximab. But in the big picture, the most important thing to my mind, and I think many other neurologists agree with this, is just to get the vaccine. Because if you get the vaccine, we know that reduces your risk of getting severely ill or dying from COVID if you catch COVID. And there's some evidence to suggest patients on B-cell depleting drugs like rituximab might be at risk for a more severe disease course from COVID. That's not definitively proven, but there's evidence out there suggesting that. So I would recommend getting the COVID vaccination sooner rather than later. I definitely would not postpone your rituximab infusion. The next question says, I've had the third shot of Moderna, the full dose. That's great, on August 16th. Am I understanding that I should get a fourth shot, a booster, after 6 months? That will be half the original dose amount. That is my understanding at this time. Keep in mind that 6 months from August, things could change. The recommendations could change. But yes, they are recommending a fourth booster dose. For the Moderna, it would be half. Now, I didn't mention this because this even complicates it even more. They're now saying on the CDC's website that you can even switch vaccines. So up to about 3 weeks ago, they were saying if you started off on Pfizer, stick with Pfizer. If you started off with Moderna, stay with Moderna. If you started off with J&J, stick with the J&J vaccine. Now for the booster doses, they are saying you can switch. And there might be some evidence, this is not definitive, but there's some evidence to suggest if you switch, that might even boost the response slightly better. So if you've gotten 3 shots of Moderna, 6 months, you want to get a booster, it doesn't have to be Moderna. It could be Pfizer, it could be J&J, it could just be whatever is available. I would say, what's easiest to get at your local CVS or Walgreens pharmacy, you can switch around now. Now, keep in mind, 6 months from August, the recommendations might change again. So double check on that, 5 months from now as it gets closer to that time point. But as of today, October 27th, 2021, my understanding is that they are recommending if you're immunocompromised, you can get the fourth shot, the booster, 6 months later. Next question starts off with, I'm confused. I apologize for that, but I had a feeling that was going to happen. I'm recently diagnosed with NMO. I recently had the first 2 doses of rituximab in September. Good, so that's important that you're on treatment. So that's good. I'm due for the 3rd dose of rituximab in March. My doctor advised me not to have the booster or the flu jab for now. I'm vaccinated against COVID. You had the 2nd dose the end of June. So, different people are going to have different recommendations about the boosters. If you got the vaccines, it looks like you got your vaccines in June prior to getting the rituximab. So that means you were not immunocompromised at the time that you got the rituximab. So actually, when you got your vaccines in June, assuming you weren't on any high-dose steroids, you hadn't gotten any rituximab at that point, then at that point, you actually should have gotten the full response of the COVID vaccine. So you could argue you don't need that 3rd dose at all of the vaccine. And the booster, you can decide on the booster dose later on. You have 6 months from the time you said you had your 2nd dose in June, so 6 months from then would be December. The recommendations have changed. You could discuss that again with your neurologist. There might be something about your particular case where they don't think it's advised. Same thing with the flu shot. I generally do recommend my patients get the flu virus vaccine, only because the flu virus, we don't know how bad the flu season is going to be this year. It was kind of mild last year because everybody was, staying home and social distancing. If you're already doing that, maybe you don't need the flu vaccine. If you telecommute and you're working at home and you really don't have much exposure to other people, maybe your risk of getting the flu is so low you don't need the flu shot. There might be individual reasons that your doctor is telling you not to get the flu shot. Next question. I had the 3rd shot of Moderna, full dose, on August 16th. Am I understanding correctly I should get a 4th shot after 6 months? That would be half the original dose. So you could do that, but again, now they're saying for the boosters, you can mix and match. So you could either get, if you get the Moderna for the booster, that would be half dose 6 months later, or you could just get a booster of the J&J or a booster of the Pfizer vaccine. I know it's very confusing. These things get updated periodically. Some of this just happened in the past few weeks. Next question. My neurologist said the COVID vaccine could have been a factor, one of the factors in triggering my NMO. Do you agree? It is possible. The only real evidence to suggest that might have been an issue is if you were not on treatment for your NMO at that point. Most of the evidence suggests that it's safe to get vaccines if you have NMO and you're on therapy, meaning you're on rituximab, Cellcept, azathioprine, maybe some of the newer FDA-approved therapies like Soliris, cetralizumab, which is Enspring, or inebilizumab, which is Plinza. Forgive me if I left out one of the other therapies that some of you might be on. So if you're on one of those therapies that's effective, it's unlikely that that would have triggered your NMO. Vaccines can also trigger what we call pseudo-relapses or pseudo-flares. You have to be aware of that. Sometimes if you had an NMO relapse, say you had optic neuritis, you recovered from it, and then you have a fever, or your body temperature goes up, or you get a vaccine, you might not have a relapse of optic neuritis again. You might just have eye pain and blurry vision as your body's responding to the vaccine. And that could very well not be an actual optic neuritis relapse or an NMO relapse. That is called a pseudo relapse. That happens a lot in MS, and it can happen in NMO also. But if you and your doctor are concerned it's a true relapse, there's things you can do. You can do, if it's vision related, you can do visual field testing. You can get an MRI of the optic nerves to look for enhancement. If it's a spinal cord lesion, that's the concern. You can get an MRI of the spinal cord to look to see if there's active inflammation in the spinal cord. Sometimes that's the only way to know that. As far as triggering NMO for the first time, yeah, certainly it's possible if you had the COVID vaccine and then you had your first NMO attack. Obviously, we're not on any treatment for your NMO at that point. If you had your first NMO attack, it is theoretically possible. I don't think that's been proven. There's been case reports of that in MS. I had an MS patient who, just as an example, I know it's a different disease than NMO, but who had optic neuritis. Well, at the time she didn't have MS. She had optic neuritis about 5 years ago, but she didn't meet the criteria for MS. She didn't have NMO or MOG, so we were just monitoring her. And she didn't have any disease at this point. All she had was optic neuritis. And sometimes that happens. People get optic neuritis, and it's not necessarily due to MS or NMO or MOG, it's just optic neuritis. She got her COVID vaccines in April of this year, both doses, but unfortunately she and her husband both caught COVID in about September of this year, very mild. They were at home. And while she had the COVID symptoms, she noticed her left arm got numb. I got an MRI for her cervical spine. She had a lesion, did not look like NMO, but I checked, her antibodies were negative. It looked like MS, and she had new lesions on the MRI. So, in her, she already had optic neuritis. She was at risk for developing MS, and did that COVID infection, that in that case, it's not the vaccine because she was vaccinated in April, but she had the COVID infection in September. Did that possibly activate her immune system, leading to her MS flare? It's certainly possible. We don't have any definitive evidence on a large scale to prove that. There's case reports out there for NMO that this happens. There's case reports in MS. What we really need to definitively prove this, though, are large case control studies. So this is where large groups of neurologists get together and they look at a bunch of NMO patients over time and compare that to patients who've gotten vaccinated who don't have NMO, and NMO patients who don't have vaccines exposures, and then looking, to get a better idea of what the true correlation is between that. I think one of the questions that popped up was, what is the fancy name of the Pfizer vaccine? It is Comirnaty. It's Comirnaty. I think it's Comirnaty. That might be how you pronounce it. I'm not 100% sure on the pronunciation there, but I think that's the fancy name for the Pfizer vaccine. But I think most people don't call it Comirnaty. They just call it the Pfizer vaccine still, because I think we're just so used to calling it that. I'm not sure if there are any other questions. I think I addressed all the ones that popped up that I saw.
I see one that says, I meant triggering NMO for the first time. I don't know if you answered that one already.
I think I did, but I'll just repeat the, so the question is, if you never had NMO and then you have your first attack, could have that been triggered by a vaccine, whether it's the COVID vaccine or any other vaccine? And theoretically, it's always possible. Vaccines activate your immune system, just like a viral infection activates your immune system. And the benefit of the vaccines is when they activate your immune system, they will prevent you from hopefully getting infected from that virus or bacteria, or whatever you're getting vaccinated against. But as the immune system gets activated, if you are already going to get NMO, maybe it'll hasten you to getting NMO, and you'll have that first attack. So it's possible if somebody has their first NMO attack, obviously you're not on any treatment for your NMO. If you're having your first NMO attack, it's possible that could have been triggered by the vaccine. Again, I don't think we have enough data to show that vaccines trigger NMO attacks. There's some data to suggest that's possible. Again, if you're not on therapy, it's all retrospective data. So I'm always suspect of these small case series where people blame a vaccine on something. There are case control studies that were done, again, in multiple sclerosis, a much more common disease. We don't really see associations with the vaccines triggering MS. But we see, people report, like I said, I had a patient where it seemed like she had the COVID infection, not the vaccine, that triggered her MS relapse. But those are all just small associations that we make, but the bigger data sets don't usually prove this out.
Are there any other questions from anyone? We have about 10 minutes left with Dr. Osborne before he but oh, I think we just got one. Could you speak again about the registry?
Sure. Yeah, the COVIMS registry, it's COVIMS. So it's the COVID virus MS registry. This is a registry that is started in 2020. It's, oh, sorry, so the V there, COVIMS, COVIMS, yeah. And the COVIMS registry is a large registry in North America. So basically the United States, Canada, I think Mexico might be involved too. And basically neurologists who treat patients with MS, NMO, and MOG can enter any patient that they know of that has one of those diseases that had COVID-19. And what, they're looking to see, their age, their gender, what disease did they have, MS, NMO, MOG, or what medications were they on when they got diagnosed with the COVID infection. Some people might not have been on any medications. Many patients are on medications though when they have MS, MOG, or NMO. And then what were the initial symptoms? So was it loss of smell, fever, cough, shortness of breath? And then what was the disease course? So did they just stay at home and rough it out at home, which the vast majority of people do? Or the small minority of cases where patients end up in the hospital? They drilled down to very detailed questions in this registry. If you were in the hospital, were you admitted to the ICU? If you were in the ICU, did you get put on a ventilator? If you were in the hospital, did you get treated with medications? If so, which ones? And then they ask outcomes, what was the recovery? And so it could be, as the worst case scenario, obviously death, which is horrible, or maybe somebody didn't go into the hospital but has that chronic COVID type symptoms. You might have heard of this. It's still not very well understood, but we're investigating this. Tends to be people who had milder COVID infections. After they recover, may have persistent symptoms that may last for several months. We don't know if this is more common in NMO patients. Again, the registry will help us figure that out. So if you out there in the audience, or somebody in the audience who had COVID, you could talk to your neurologist and ask them to enter you into the registry. And as we get more and more numbers, we're going to learn more and more about how COVID affects the patients with NMO and MOG disease. Now, here's another couple of questions that just popped up. Of the 3 monoclonal antibody treatments, is there one I would recommend for NMO patients on rituximab or other treatments over others? I don't think so. So I would just say whichever monoclonal antibody is available to you. There are 3 of them that are approved. Most of them are IV. I think one of them does have a subcutaneous option, meaning that you wouldn't have to go to an infusion center. You could get it a sub-Q injection. But for the majority of them, it might just really depend on where the what drug is available at the clinic you're going to. So the monoclonal antibody treatments are usually in an outpatient setting. So if you get rituximab infusions at home or at an infusion center, I know at the Georgetown system, we have our sister hospital in DC called MedStar Washington Hospital Center. We're sending, I think, all our patients to their infusion center for the monoclonal antibody treatments. I don't think there's any data to suggest one of them is better or safer for patients who are on rituximab or any of the other therapies. The next question is, do you see any significant differences in the recommendations or strategy regarding NMO and COVID vaccinations in the US and Europe? That is a great question. So there are different vaccines available in the US and Europe to begin with. I know I saw an article just recently that the country of France has already ordered a large number of doses of that pill that I mentioned that Merck is investigating. The FDA has not even approved it yet in the United States. So I don't know when or if that drug will get approved in the United States, but apparently France is already ordering. I guess France has reviewed the data from Merck on that pill. They're already ordering the drug. I think there are some mild differences as far as booster doses and interchangeability. Some of that has to do with just they have different vaccines available in Europe. So for example, the AstraZeneca vaccine you might have heard of is available in Europe. That's not available in North America, or at least in the United States. But I think the general idea is that if the message is if you're not vaccinated, get vaccinated. And I think still the general recommendation, if you have NMO, if you have MOG, if you have NMS, if you have multiple sclerosis, if you're not vaccinated, get vaccinated. Again, there might be mild differences, recommendations. There might be an individual out there who was told not to get vaccinated yet, and that might be because of something individual about your case. I'm just talking more broadly for general populations of MOG and NMO patients. And for the registry, there's a question, do you mean the registry for COVID while already diagnosed with NMO? Yes, so this registry is looking for patients who already have MS, NMO, or MOG, who then go on to catch COVID. So if you have NMO already, you have MOG already, or if you have MS, and then you happen to catch COVID, the point of the registry is to figure out how do patients with these neurologic diseases, these autoimmune diseases that affect the brain and the spinal cord and the optic nerves, how do they fare? Do they have a more severe disease course? So far, we don't tend to think so. We don't think NMO or MOG independently is a risk factor for a more severe disease course unless you're already debilitated by the NMO. That might put you at risk for a more severe, so if you're already bedridden from the NMO, that might be a risk factor for a more severe disease course because COVID affects your lungs. If you're bedridden, maybe you can't ventilate your lungs as well, so you could have a more severe disease course. So that's the point of the registry, the COVIMS registry. And I think that was put in the chat box, the link actually to the COVIMS registry. Do you recommend the monoclonal treatments, not just for testing COVID positive, but coming into contact with somebody who's COVID positive, as my neurologist recommended? I don't think they're indicated for that. So if you've been exposed to somebody who's COVID positive, but you're asymptomatic, the monoclonal treatments I don't think are approved for that. And I know at MedStar, you wouldn't be eligible. There might be an individual reason why your doctor might have recommended that, but in general, the FDA indication is for people who are COVID positive. Getting tested for COVID, fortunately, has not been an issue recently. If you remember last year, it was very problematic getting tested. I think in general, that's not as much of a problem in the United States. There might be certain parts of the country where it is tough, at least in the DC metropolitan area. It's very easy to get tested for COVID now. They have testing kits at CVS you can get, do the testing at home. I think you can order the COVID testing kits on Amazon and get them shipped to your house. So I think that answers that question.
This was incredible. Dr. Osborne, thank you so much for your time and your expertise on this ever-evolving topic of COVID-19. I'm sure that all of the people who were on this webinar truly enjoyed this and found it to be useful. Thank you so much. And again, just a reminder for those who would like to reference this after the fact, this will be available on TSF's YouTube and Facebook video libraries and will soon be available in other languages as well. Thank you again, Dr. Osborne. This was incredible and we'll hope to see you soon.
Bye.
Ciao.